This is part 6 of a series of lectures on antimicrobial resistance and antimicrobial stewardship in veterinary medicine. In this final part, we'll be discussing how we can control the development of antimicrobial resistance, what we can do about it, and how we can address it in the future. So, to finish, we're going to consider how we may be able to control antimicrobial resistance in the future. It's clear that resistance existed well before we started using antimicrobials therapeutically. So we cannot really prevent this resistance arising in the first place because these resistance genes are around the organisms that we're trying to treat all the time. However, we can limit the dissemination and accumulation of antimicrobial resistance, and particularly the development of multiple resistance. The way we can achieve this is by limiting our antimicrobial use now. If we start limiting our antimicrobial use, we'll delay and possibly prevent future limitations that are going to be imposed upon us. Those limitations that will be imposed upon us in the future, if we do not limit our antimicrobial use, are likely to be both biological and legislative. By biological, I mean that the drugs that we are currently able to use effectively will no longer be effective in their use against particular pathogens. But there is also the risk that if we do not voluntarily control our antimicrobial use, there will be the imposition of much more strict regulatory regimes on antimicrobial use for domestic animals in the future. So where are the selective environments that we might be concerned about? Antimicrobials are used in animal agriculture and are sometimes present in both products and byproducts of animal agriculture. There is considerable use of antimicrobials in medical hospitals, and they are present in their patients, so these are also a selective environment. Selective environments can include veterinary hospitals and their patients. They can include plant agriculture and products of plant agriculture. They can include aquaculture. Wastewater treatment plants are a particular source of very considerable exposure to antimicrobial drugs, because many of the antimicrobials that we use therapeutically are excreted, particularly in urine, in an unchanged form, and so will accumulate in wastewater treatment plants. There is also a selective effect of biocides like disinfectants and heavy metal ions when they are used in households and in animal facilities, and these can select not only for resistance to these disinfectants and heavy metal ions, but also co-select for resistance to the therapeutic antibiotics that we are mainly concerned about. And lastly, there can be quite heavy contamination around pharmaceutical manufacturing sites, particularly in the wastewater that is discharged from pharmaceutical manufacturing plants, although this is most commonly a problem internationally rather than within Australia. So what can be controlled? We can control dissemination of resistant clones of bacteria by implementing adequate levels of biosecurity on our domestic animals. We can control selection of resistance genes by controlling our antimicrobial usage and restricting it to just those times when it is absolutely necessary. We can control our co-selection of resistance genes, again by controlling antimicrobial usage. We can control transfer across both bacterial and animal species by implementing both adequate biosecurity and by implementing controls on antimicrobial usage. And lastly, we can implement some control on reservoirs in the environment and in other animals, again by implementing biosecurity and by controlling our antimicrobial usage. So ultimately, other than imposing adequate biosecurity in our domestic animal species, the major thing we can do about restricting the development of antimicrobial resistance is to use our antimicrobial drugs responsibly. This requires us to use these drugs only when they're going to make a difference to the health and welfare of the animals that we are looking at. We should make sure that we use the most appropriate antimicrobial drug for the case that we are seeing. We should ensure that we always use these drugs at the right dose and only for as long as is necessary to achieve an optimal clinical outcome. What we need to keep in mind is that using an antimicrobial to which a pathogen is resistant has the potential to exacerbate the disease that we are seeing rather than achieve some improvement in that animal's outcome. Much of the discussion about antimicrobial use and about the development of antimicrobial resistance often descends into attribution of blame to particular groups of prescribers or users of antimicrobial drugs. And while most resistance in medically important bacteria is actually not attributable to veterinary use, with examples such as nosocomial multiple resistant Staphylococcus aureus and resistance in Streptococcus pyogenes and Streptococcus pneumoniae, and the development of vancomycin-resistant enterococci in North America as particular examples, there is some development of resistance in medically important bacteria that has clearly been associated with veterinary use. And this includes vancomycin-resistant enterococci in Europe, which were associated with avoparcin use in both pigs and poultry, with the development of fluoroquinolone resistance in Campylobacter jejuni in North America, which was associated with the use of fluoroquinolones in poultry, and the development of multiple resistant Staphylococcus aureus in association with pig and veal calf raising, particularly in Europe, but increasingly across the globe. Ultimately, this discussion of blame and fault is not particularly useful, because bacteria don't respect species or geographical barriers, and ultimately this is really a shared problem with a need for shared responsibility. We need to consider which antimicrobials should be subjected to restricted use in veterinary medicine. It's particularly clear that the newer broad-spectrum antimicrobials, and particularly the fluoroquinolones and the later generation cephalosporins, should have quite restricted use in veterinary medicine. We need to be cautious that easier dosage regimens are not driving our choice of antimicrobial drug. It's not appropriate that a particularly convenient method of administration or regimen for administration is the main factor that drives our choice of a particular class of antibiotic. We need to be cautious when we use antimicrobials that are not registered for veterinary use, and we particularly need to be careful about custom compounding of antimicrobial drugs. And lastly, growth promotant use of antimicrobial drugs is clearly not justified. So to finish with, we need to consider the measures we should be implementing in veterinary practice to ensure good antimicrobial stewardship. These include implementing guidelines and policies to ensure that we use the drugs appropriately and to ensure that we have agreed points at which we halt therapy. We need to ensure that we understand the pharmacokinetic and pharmacodynamic factors that influence the efficacy of our therapy. We need to ensure that we understand the factors that will influence the duration of our therapy. And we need to ensure that we make increased use of diagnostic microbiology and ensure that the laboratories we use test and report the most appropriate range of antimicrobial drugs for the species and for the pathogens that we are dealing with. In addition to these measures, we should monitor and benchmark our antimicrobial use and the resistance that we see in the pathogens that we are treating. We need to ensure that we develop infection control policies and procedures that we have in place in veterinary practices. We need to ensure we use vaccines and other management procedures that replace our reliance on antimicrobial therapy for controlling infectious disease. And we need to ensure that we understand the role of other antimicrobial agents in the selection of resistance, and particularly the role of disinfectants and heavy metal ions. Finally, we need to develop and assess our antimicrobial stewardship standards and ensure that we engage in good client and public education about antimicrobial stewardship. Continuing education is needed to ensure that we engage in the best antimicrobial use practices. And we need to recognise the importance of this antimicrobial stewardship in the ongoing welfare of both humans and domestic animals. So how can you approach antimicrobial stewardship at a practice level? Firstly, you should appoint an antimicrobial stewardship coordinator in your practice. You should then determine which antimicrobials should be on restricted and reserved lists for your practice. You should review your current usage patterns and institute an approach to the use of diagnostic microbiology and compilation of the data from it to guide your antimicrobial usage. Your usage should be reviewed regularly, and the resistance data should be reviewed annually to ensure that your choices of antimicrobial drug therapy are still in accord with the resistance data that you are gathering. And you should coordinate this antimicrobial stewardship program with an infection control program. Antimicrobial use is best considered using a tiered usage pattern. This usage pattern should consider having at least 3 tiers. A first-line group of antimicrobials which are used in situations that are commonly encountered. And secondly, a restricted group of antimicrobials that are only used in particular situations when their usage is particularly indicated by that particular situation. And finally, a reserved list of antimicrobials that should only be used when diagnostic microbiology recommends that they are the most appropriate drug for that particular situation. Of course, all of this usage should consider local jurisdictional restrictions on antimicrobial use as well. And lastly, a word about effective surgical prophylaxis. Although there have been limited studies in veterinary medicine, it is clear from studies in human medicine that prophylactic antibiotics should be administered within the hour prior to incision of the patient. It's clear that a single preoperative dose of an antibiotic is as effective as a 5-day course of post-operative therapy, assuming the procedure was not complicated. During prolonged procedures, it's appropriate that antimicrobial prophylaxis is re-administered every 2 to 3 hours during surgery. And lastly, it is critical that prophylactic antibiotic choice should be guided by the anticipated organisms that might be found contaminating the surgical site.